Right. Well, let's go ahead and get started. And I know it's lunch hour for most people, so we'll just keep letting people in as they come. Um, but today we have the Center for Developmental Psychiatry, and we have Dr. Dean and Dr. Patel joining us. And so I guess I'll just start with Dr. Dean. Do you want to kind of tell us a little bit about yourself and tell us about the Center for Developmental Psychiatry?
Sure. So, hi everybody. I'm Dr. Jason Dean. I am an adult psychiatrist. You can hear me okay, by the way?
Yep.
Okay. So I'm an adult psychiatrist and a child psychiatrist. My approach to psychiatry is really based on combining a psychotherapeutic way of looking at things, and I'll explain what I mean. So, um, we see patients who come in with different symptoms, usually that bring them into treatment, like anxiety or ADHD or things like that. Um, and then we talk about the symptoms, we come up with a medical diagnosis, and then think of a medication. Um, but the way that I like to look at things is actually that symptoms are really just the tip of an iceberg, tip of the iceberg, and that they stem from underlying social, emotional, developmental issues. Um, who somebody actually is as a person, as a human being, family dynamics, things like that, their psychological makeup. Um, and so when I was in my training, I did a lot of extra training in psychotherapy, specifically psychodynamic therapy, which is based on the idea of understanding these deeper underlying issues. And then when working with patients, I really like to understand them in that deeper sense, and actually in my actual practice, I do therapy most of the day. So, providing what's called like integrated treatment, where I do the medication management together with psychotherapy, which that's actually the way it was always done in the past, but that's kind of not what most psychiatrists do nowadays. But then, even when I'm not doing therapy, most of my patients, if I'm just prescribing medication, also the idea is to kind of take that lens anyway. We meet with people, instead of, a lot of psychiatrists will do 15, 20 minutes every few months. We'll meet with people like for 45 minutes once a month. So the goal is really to spend a lot more time with people, really hear where people are coming from, really get a much deeper understanding of what's going on. Providing psychotherapy when people don't already have therapists. That's kind of the model of how the practice works. And we have four psychiatrists altogether at this point. And everybody that I've kind of brought on to join the practice similarly is interested in psychotherapy and has a very similar view. I'll introduce Dr. Patel in a minute. She'll tell you more about herself. We work with children and also adults. So we see children as young as 2, all ages of children, teenagers, and adults. And one of our psychiatrists is an adult psychiatrist, so he can see adults of really any age, even elderly patients. So we definitely have a focus on child psychiatry because we have 3 child psychiatrists, but all 3 of the child psychiatrists, myself included, will see adults as well. So we see all those ages. I think we see a lot of teenagers and young adults. That's like a big part of our practice, but we see the younger kids as well. And we treat basically all conditions, but I would say some of the more common ones are ADHD. We see a lot of ADHD, a lot of kids on the autism spectrum. We see a lot of anxiety, behavioral issues, things like that. That's usually with the younger kids. And then teenagers, a lot of depression, even self-injurious behavior. Actually, as I mentioned, that I'll say also, we are comfortable with kind of all levels of severity for the most part. Some private practice will kind of not want to take patients who are, let's say, cutting or things like that. And then as we get into the older, like young adults and things, usually a lot of depression, bipolar, things like that. Yeah. So that's our practice. The main idea is really to spend more time with people and to try to really kind of have that deeper understanding, and have a more therapeutic approach. That's kind of like a summary.
That's really great because I think working with children in schools and things, and different communities, I think that's something that's really been missing for quite some time. I'm not really sure the driving force of why, other than insurance costs and all of that kind of driving that. But I feel like a lot of my clients and kids I've worked with in the schools often have a psychiatrist for medication management, somebody else for therapy, then you know, their PCP or primary care physician for some of the other things. And sometimes things aren't communicated between, and the fact that coming to the Center for Developmental Psychiatry, you can have all kind of get it all, and the same person prescribing medication is also getting a real insight and lens to the symptoms or the concerns that are leading to that treatment, or the combination of different treatments. So that's really great.
Exactly. And then even if we're not doing the therapy, we have Natalia here as well, who'll hopefully introduce herself later, but she helps us collaborate with all of the therapists that we work with. So we have a lot of really strong relationships with therapists in the community. So even if we're just doing the medicine and we're not doing the therapy, we meet with the therapist at a certain frequency. So we kind of compare notes. And so we still have access to all that deeper information, so we can use that to help us, inform our prescribing. That's a really big part of what we do too.
Do you partner with schools sometimes too, or can you help with that?
So
Especially when
we
you get into
actually,
some...
yeah, I mean, everything I was talking about was like the clinical aspect of like patients coming in, but we, as a big part of what we do, actually, we contract with schools to do third-party evaluations of students who, they need like clarification on the diagnosis or recommendations for what to do in school. So we actually have a lot of experience. We're contracted with, Natalia might know better than me, I think like 20 or 30 schools in New Jersey. So
Oh, wow.
we do a lot of school evals. And that's where the school is kind of asking us, but then for our private patients, we're very comfortable kind of weighing in on those kind of things, writing letters, talking to the school, and helping with all
Yeah,
of it. So that's a huge part of what we do, actually.
wonderful. So are you going to introduce Dr. Patel to us as well?
Yes, this is Dr. Patel.
Thank you.
Okay, I didn't know if there was anything else to share. I'm sorry.
No, thank you. So my name is Divya Patel. I am also a child psychiatrist as well as adult psychiatrist. I share a lot of the views that Jason just shared about my sort of approach to medications and kids. I think especially with kids, I like to really work with the families and the schools. So collaboration has been a really big part of my practice so far. And again, I think it's like what he was talking about, really understanding the environmental and emotional factors that are contributing to whatever issue the kiddo is having. So I really enjoy doing that. And I think it's really impactful for a lot of families. I tend to spend a lot of time with my families to really help give like parents guidance also of how they should be talking to their kids, or how to approach difficult conversations if the kid is having, for example, suicidal thoughts or struggling with social issues. Sometimes it's a really difficult thing to open up those conversations, but I usually do a lot of work with parents to help them feel comfortable talking about these things, so that way when things become more difficult or when things worsen, it's really open space for communication. I'm pretty comfortable working with kids as young as 2, 3. I did a lot of work with kids with autism. So I would say autism and ADHD are probably the most common issues we see a lot. But like I said, we see sort of the whole gamut of problems. And I think that oftentimes once people connect with us and once they form a relationship with their doctor, and once we've spent so much time, even with the intake, to getting to know the kiddo, things tend to get better. So we do also see that where, things might be feeling a lot for the family and for the kiddo. But once they connect and have a plan, which we try our best to do that, things tend to get a little better. So I'm glad everyone is here, and we're open to whatever questions you guys might have, or anything you think would be helpful for us to talk about, so that way you have a better understanding of when to seek help and what to seek help for.
And Natalia, do you want to tell us a little bit about what you do at the Center for Developmental Psychiatry? I have to keep thinking and not say psychology. I'm sorry.
Yeah, so hi everyone. Thanks so much for being here today. My name is Natalia and I'm the outreach manager here at the Center for Developmental Psychiatry. So I do work very closely with our team of psychiatrists to kind of connect families with any other types of support they need. Also, we're really big on collaboration, like Jason and Divya had mentioned. So whether that's connecting, the doctors with other therapists or schools, counselors, really anybody else, just to make sure that we have the best picture of what's going on, and everybody is on the same page. And on a personal note, I am a new mom to baby girls, so it's kind of taken on a different meaning, you know, helping families. So I'm really excited to be part of the conversation here today.
Well, congratulations.
Thank you.
It does change our work when we become parents, and then kind of straddle both sides of the table, right?
Right.
So I wanted to just kind of outline for everybody how we're going to do things today. I put a text in the chat that you're welcome to ask questions there. You're welcome to unmute, camera on, camera off, and ask questions directly. I think that I work with a lot of parents that are struggling with attention concerns or executive functioning concerns. And one of the big questions I get is, you know, when is it just typical behavior, or what are the signs that we should seek professionals or get an evaluation or start therapy? Is there any advice you give to parents when they're kind of in those beginning stages of when do we need professional help?
Typically, so I think that's a really good question. And I feel that it really depends, but typically my approach is, if you're having the question, there's probably something you're seeing, right? That is either making the child uncomfortable, or you're seeing signs of stress. So typically what I suggest if you're seeing signs of stress, there's likely something going on. Now, if it's educational, if it's emotional, that's something we'll have to kind of talk and figure out. I think the benefit of an evaluation, especially with a child psychiatrist, is that it kind of covers the whole range of problems that might be going on that might be causing stress, right? And so sometimes I tell parents that if it's feasible and it makes sense to have a consultation, then at least you can have a good understanding of socially, emotionally, academically, what kind of vulnerabilities your kiddo might have, or is this something that has already progressed, let's say, to a challenge that we should be doing something to address. Oftentimes we will sort of go in depth about whatever problems might be coming up, let's say in the school setting, if this sounds like something that's related to a biological, environmental kind of challenge, or versus something like ADHD. Overall, I would say that anything that's happening that you feel like is interfering with the child or the family's quality of life it is typically significant, right? And so I think that that's a general answer, but hopefully that gives parents a thermometer. You know, if it's something that they feel like they are managing and the school feels like they are managing, and socially the kid is doing okay, then maybe that's something you monitor. But if you as a parent feel like, I'm struggling to manage this behavior or this challenge, and you're getting input from school, for example, that this is getting challenging, even with whatever approaches they may be trying, then maybe it's worth taking a deeper dive into why that might be, and understanding what you can do to be proactive. I think oftentimes, a lot of the times when we see kids, things have already occurred, or they've had experiences that have caused a lot of stress emotionally. And so I try to encourage parents to be proactive, just because at the least you'll gain a better understanding of your kiddo, and at the most, hopefully identify something that is treatable or addressable in some way.
I think that's really helpful for parents, because so much of the time, especially if a child's in different settings, you know, they present one way with at home, another way at school, maybe another way at aftercare, or in multiple households, if they have multiple households or family members that help share in their care. So that validation of, if you're concerned, go ahead and reach out, I think is really reassuring to trust that gut feeling that there's something going on here, and let's figure out how to support. We have a question in the chat. The parent said, glad to hear about the parent training aspect. It's so important. Are sessions virtual, in person, or both?
Yeah, that's a good question. So I recently joined the practice, and both myself and Jason have in-person availability as well as virtual. So again, we try to be flexible and try to work with families to figure out what will work best. I typically like to see the younger kiddos in person. So again, we can do a lot of the behavioral kind of observations or play-based observations that might be impactful or helpful for me to understand what's going on. It's not always possible. We have a lot of experience working with kids virtually too, especially with COVID. So we have it figured out both ways. I would say whatever works best for the families. Oftentimes we see parents. So I guess I should mention the way that our intakes are structured for kids is that it's the intake is 4 sessions. So the first session will be just with the parents, which we oftentimes do virtually. And it's a lot of information gathering. So again, it's me trying to understand what's going on, why you're seeking the consultation, what kind of observations you have made. And so I think that takes away the element, like you're right, sometimes kids will present and they'll say, I'm good, everything is fine, why am I here? And so that's what we try to meet with the parents first, understand, what might be going on or what might take some time for us to view with the child once we build a relationship. And then there's 2 sessions, 45 minutes each with a kiddo. Usually within a couple of weeks, we try to schedule that in again to spend some time gathering information with them, but also just building a relationship and trying to understand personality structure, environmental influences, and things that might, not come up from, let's say, one meeting with the kiddo. And then the last session is a feedback session where our goal is to give parents a comprehensive treatment plan, give them a good understanding of what kind of challenges or vulnerabilities we might be seeing. And hopefully they can leave that 4th session with some sort of game plan around, whether medications would be necessary, treatment with therapy, what kind of therapy, as well as any collaboration with school or any other professionals that are in their team.
Okay.
I'll add, by the way, that
Yeah.
with these evaluations about whether or not to have an evaluation, we don't push medication. I know a lot of people are worried that if they're seeing a psychiatrist, they're going to automatically have to put their child on medication. So we really don't. Most of the time, people don't usually want to see a psychiatrist. So by the time they get to us, usually they could really benefit. But we've done evaluations and said, therapy would be, it was fine to start with therapy. You don't need medication. But then at least and I think that goes back, like the fact that we do therapy, I think helps us also do that, because what's the saying? If all you have is a hammer, everything looks like a nail, So like if all you do is prescribe medicine, you tend to just see ways to prescribe medicine. But we can offer therapy, we can offer parent guidance, we can offer to kind of check back in 3 months or 6 months or something like that. But I think of an evaluation as almost like you walk into a room with the lights off and you're like bumping into all the furniture, you turn the light on and then at least you can like see, you know what I mean? So getting a really good quality, high quality evaluation, at least that you can just see everything that's going on. And then, you're just not committing to anything.
Exactly. And yeah, we spend a lot of time providing resources or education also around, let's say I see a kiddo and they came in for anxiety, but I'm actually really concerned about ADHD. And then I'll spend a lot of time at the feedback session, sort of explaining why and providing more like information on the science behind ADHD, why medicine might be helpful. And then oftentimes my parents, I give them sort of some time, like digest all the information, think about it, talk to your family and see if it makes sense for you. But at least you have all the information. I think our goal is just to make sure that people are making informed decisions, especially about their kiddos, and that they have access to high quality information, people who have a lot of training and backing around recommendations. I think it's hard to find nowadays. So that's usually our goal.
That's all like great. And I think you're right. That I think a lot of parents think, and I think professionals in the schools and stuff also have that belief, or that's been my experience, that you need the psychiatrist if you're going to do medication. And if not, you can do a psychologist or a counselor or therapist. And so it's really great to hear that your approach would be looking at all the different options for therapy. And whether that's medication or behavioral or cognitive therapies, doing that. So that's great. I don't see any more questions in the chat. So we got one. Hi, sorry to join late and may have missed it, but do you do neuropsych evaluations? Is it different from the evaluation that you do? My kid is officially diagnosed with ADHD by developmental pediatrician. However, I'm still interested in to understand the areas of her strength or weakness.
Yeah, so we don't specifically do neuropsychological evaluations. So that would have to be done by a neuropsychologist. And typically it would be, again, a one-off sort of thing where you do a lot of testing and it helps them test for things like processing speed or memory and their specific abilities like in math and reading and things like that. And then oftentimes at the end of those evaluations, you'll get a report sort of highlighting what you're saying, like strengths and weaknesses of the child. But our evaluation will mostly do like a clinical focus, right? So it will be based off of only speaking with the parents and speaking with the kiddo and our observation. So again, it's more based off of how the child is presenting and what kind of challenges the child is having. And that's how we've been trained. So neuropsychologists, it would be more of a testing based approach, and ours would be more of like a clinical understanding based approach. I think in most situations both can be valuable in different ways, but the big difference that I have a lot of confusion sometimes with parents is that neuropsychologists cannot prescribe medications in New Jersey. So typically they'll give you the insight and then sort of give you the recommendations to see a psychologist if they feel that medication could be helpful, but essentially their job is to just give you this report outlining, how your child is functioning in these different areas of cognitive tests.
And I was just going to add, and you can add it in there and I'll let you speak. I'm just wondering if you could give some examples. So if a child has ADHD, it looks like you answered this parent's question, but if a child has ADHD and parent still has concerns and you would do a further evaluation, could you like just give some examples for a parent of what else you'd be digging into to uncover that maybe would be different from a neuropsych? Because I do think parents hear a lot from schools, you need a full neuropsych, when maybe what they're at, if they're looking at certain characteristics, you might be a better fit.
Yeah, so when I'm looking at whether or not to prescribe medication, for instance, you can make the diagnosis sometimes in less time than we're spending on these evaluations, right? And you could say, yes, this is ADHD and this is the medicine I would use, but it doesn't tell you if you should take medication, right? Or how strongly I would recommend that. And I think that's actually the real question. And I think to answer that, then you have to really get into that deeper understanding of kind of who this child is and how they're functioning in terms of their social emotional development. That's actually why we do the two individual, well, there's a couple of reasons, but one of the main reasons why we do 2 sessions individually with each child is to get that second kind of, the second session, at least the way I do it is usually to go kind of deeper in that second session. So as an example, you could have a kid who has ADHD and like, yes, they've been diagnosed and they definitely have it. But they, their self-esteem is fine. They're doing fine in school. They have friends. They don't really have many issues. That's dramatically different from a kid who is developing really poor self-esteem, is starting to do poorly in school, right? Is getting in fights with their friends all the time because they're impulsive and they're kind of cutting in and like, getting in these fights and stuff like that. And so, I think what's different about our evaluation than a neuropsych, the neuropsych will tell you if they have ADHD, although I would say that I very rarely feel that someone needs a neuropsych evaluation to actually diagnose ADHD.
There we go.
Yeah, but a neuropsych helps with, let's say, learning disabilities. Like it's very hard or impossible for me to tell, does a child have dyslexia, let's say, right? Or do they have like a learning disability in math or something like that? Dr. Patel mentioned processing speed. So that's just how fast you think, basically. There could be different issues with like memory or different kinds of reasoning that could be, so I usually recommend a neuropsych when there's a lot of issues going on in school academically and we're not sure why. Like it doesn't seem to be just ADHD, but if it seems like ADHD, is probably the main thing, then a lot of times I would just start a medication and see what happens and wait, because the medicine works very, very quickly usually if you're using a stimulant. like Ritalin, it usually works like right away most of the time. So you can kind of like wait and see what happens, because the neuropsych, those are expensive and they take like 10 hours of testing, and it's a really big thing. But I would say that's the main distinction, that the neuropsych helps a lot with these neuropsychological things like the processing speed, learning disabilities, things like that. When it comes to, Dr. Patel was talking about like the clinical diagnoses like depression, anxiety. We read a lot of these reports, and you'll probably agree, Dr. Patel, at the bottom, it will say, your child has an anxiety disorder, you should see a psychiatrist. Yeah. So I think then parents feel kind of like, oh, what, I did this whole evaluation and now I have to go see a psychiatrist. So they're both valuable. I think of them as complementary. But in our evaluation, we're trying to also get that understanding of like, who is this person and how are the symptoms impacting their development? And how would prescribing a medication potentially change that developmental path? That's the main goal.
Okay, that's helpful. Were you going to add anything else, Dr. Patel? Oh, we have another follow-up question there too. I know you don't push for medications, so what would you recommend for someone whose biggest challenge is inattentive ADHD and related executive functioning issues like time management, planning, organization, etc.?
I know, like, obviously we like to kind of keep open conversation around medications. It's a really hard decision for parents to start medications for their kids. And at the same time, we definitely do recommend medications when we feel that it is appropriate. And ADHD is one of those disorders that we probably tend to recommend medication sooner than anything else, right? Something like anxiety or depression, we do try our best to really acknowledge and lean on the behavioral supports that we have in place or can put in place. But like you mentioned, with the inattentive ADHD, executive functioning deficits, depending on the age of the child, it can be really difficult to lean on behavioral supports such as coaching or time management, for example, when the child developmentally or cognitively is not at a stage where they would be able to absorb some of those suggestions or coaching. So I would say it depends on the age of your kiddo, but medication tends to be first line for ADHD due to that reason. One, it works very well, and two, we know pretty quickly whether or not it's the right fit for the child. And it can be pretty life-changing for the child and the family if it truly does help them, lock in and zone in ways that's innate to their innate ability, right? We're not trying to enhance them or change them in any way, but we know that the science behind ADHD points to a lot of dysfunction in the dopamine system and the attention system in your brain. And we know that stimulants do really directly target that. So I guess I hope that answers your question, but we do think that medicine is probably the most helpful tool we have in treating kids with ADHD, especially the younger ones who might be acting out behaviorally or who might have a lot of trouble, participating in the higher level behavioral approaches we might have. If your child is older, for example, 5th grade and above, there's a lot of executive coaches in New Jersey that will work with your kiddo one-on-one. We tend to use it as an adjunct, like a tool in addition to medication and therapy, again, to target specific deficits. Like if they're really having a hard time for getting their assignments or getting to class on time or getting somewhere on time, the coaches will work with the kids one-on-one to develop habits that they can, use for the rest of their lives to be functioning in whatever ways they want to.
That connects to some other doctors that I've worked with in the past, have explained it to me or to parents I was working with that, we kind of need the medication to help the brain like focus, stop the impulsivity so that they can practice those tools that you're talking about, that the executive function coach or teachers or parents to help them learn some of those skills. They need to be able to attend and have the attention long enough to practice it and find success in practicing it. Another question related to that came in was, do you find that most children who benefit from medication need it for the long term? In cases where they do not, how do you know when to wean students off meds?
Yes, so that is a pretty common question we get, and I think it's a very valid question. The way, at least I can speak for myself and Jason, because we've talked about it a lot, and it's a pretty big conversation in our practice. We tend to view medications as tools, right? So depending on what developmental stage your kiddo is at and what kind of challenges we're helping the child navigate, we're using the medicine as a tool. Like you mentioned also, Megan, a lot of the emphasis is in them being able to participate in the behavioral strategies, right? So if the child is using medication for anxiety and is better able to participate in therapy and learn coping skills and do better, then we can eventually consider tapering off the medicine and observing how they do. So in the cases where we feel like it might be okay to wean off medicine, it's usually children who've had sustained improvement in whatever challenges they presented with from 6 months to a year. That is at that point where we start having conversations with parents of, things seem to be going okay. Let's slowly decrease the medication. At least in my training, I go pretty slow and observe and see if things remain sustained and things remain positive. Then again, we help children lean into the behavioral strategies that they're learning, use them. So it's not that they won't have similar challenges, but we really try to see if they can use a lot of the skills they've been learning, let's say for the last year, to navigate it better, to decrease the stress that they're experiencing. So that's pretty much how I think of medications. I will say ADHD is probably the only exception where, again, we know that stimulants work. We talk a lot about their side effects, but I think that the risks of untreated ADHD is something that probably a lot of more people should be talking about. And so if we do find, for example, that starting a stimulant has reined in the impulsivity, has given the child an opportunity to get positive feedback from adults, right? From school, from their parents, from their friends, that typically tends to be a pretty good marker that the medication is going to be needed, at least for the foreseeable future, right? And then the child, once they're older and is out of school, for example, they can see and make a decision how they want to structure their life. I have a lot of friends and colleagues and stuff who have structured their lives as adults that maybe they don't need to use the medicine as much as they were when they were younger. So I would say for parents, it would be looking at the kiddo's life and seeing what the impact of the medicine is and weighing it against the side effects or any of the challenges they might be experiencing from the meds, and kind of making a decision of whether or not this is something that should be long-term. But that, again, ADHD is really the only diagnosis where that would be true. Otherwise, any other medicine we use, we're always reevaluating and seeing if it's necessary for kids.
Could you explain, because I think when I've worked with families and had young children, parents concerned about starting the medication and some of the risks or side effects, or is it going to change my child's personality and different things, or just the social judgment of my child needs medication because he's not behaving in school, which is just, and I'm not saying that that's true. It's just a common experience or a way a parent feels with the information they're getting from the school. One of the families I worked with, and it was like one of those moments in my career where I was like, I need to be much more open to this, because I really felt like if a child was struggling in kindergarten, it was our job as the adults to structure that environment and to help them. And I was kind of had the belief that, medicating, let's try all these other things first. And when I had a child come back, and the mom shared this, the child didn't share, but he came home from school like first week on medication. He's like, Mom, I'm not bad anymore. I was able, and he talked about all the things he was doing. My heart just broke, because here we are, this 5-year-old thinks his first start to school is he thinks he's bad, when we know he needs support, and he needs different support than what we've set up for the whole class. But he's internalized not being able to meet those expectations, as that he's bad or less than, or not making good, and that it was like a choice, I guess. So that definitely opened my eyes, and I'm glad that I had that experience as early on in my career as I did, so that I didn't kind of put up that wall when they were young, and I was more open to it. And I learned more along the way, and I don't still hold those beliefs. But I think I run into a lot of parents of young children that are at that stage too. And so one of the things that I have found helpful, and I don't have the background to do it, that I think you guys can help with is, can you just explain kind of like bird's eye view? Why is medication, when you say ADHD is the one we're going to recommend, what's happening in the brain and how does the medication help? Why that's the treatment that makes the most sense for so many?
So I think for ADHD, so, I mentioned how much we love therapy. But the irony is with ADHD, medication works like the best of anything we treat, and therapy doesn't really help the ADHD itself. So if you can't focus well, there's not that much you can do to make your focus improve. The medicine works in 70 or 80% of the cases. And when it works, it's like often transformational. So it works incredibly well and it works right away. Therapy helps like everything else. So like the child who feels like they're a bad child because they have ADHD, therapy can help with the feelings of self-esteem and all that stuff, self-concept. But it won't really change the ADHD usually. The executive functioning coaches can kind of help someone compensate for the executive functioning issues. But I think at least when I think about it, that's why I kind of think of medication usually sooner rather than later, as opposed to, let's say, anxiety, where there's evidence that therapy can help anxiety, medication helps anxiety, the combination helps better than either one alone. But I think that's why for ADHD, you can really get in there. And it's like when someone comes in and I'm hearing the story and I think, oh, I'm probably going to end up diagnosing ADHD, I get excited because the vast majority of the time you're going to end up making a really nice improvement with medication. So that's how I think about that. But when it comes to depression, anxiety, there I think it's a question more of like degree. I usually think of 3 domains when I'm thinking about these things. I think of subjective distress of the child, like how a child who says I'm bad obviously doesn't feel very good most of the time, right? Or if they're having tantrums or like really like sometimes the power struggles are so intense at home. And then there's functioning. So, children have to function at home, they have to function in school, they have to function socially. And then I think the most important is the developmental trajectory. So Dr. Patel kind of mentioned untreated ADHD leads to increased risk of divorce, incarceration, and drug use. I think of that in a developmental sense, that these children, the 5-year-old who feels like they're a bad person, if that keeps going for 20 years, compounding, you don't end up getting a person who can derive satisfaction from life, so then they turn to drugs, things like that. So this is why I think medication can be really helpful when you kind of do it early on. Yeah.
Connected to this, we have a follow-up question. So parent says, I believe the medication, all trial and error for specific individuals, and could have side effects. Do you know if there's been any medical research or studies going on to move away from this trial and error approach? I'm just nervous to do this trial and error approach.
Yeah, I guess I can speak to that a little bit. There is no way for us to predict a response to a medication in a kiddo, right? That being said, one of the value of doing a comprehensive evaluation and spending time with the child for 2 sessions and talking to the parents is that we sort of are trained to look for what kind of things might be challenges to medicine, right? So if I'm having a kiddo who has pretty severe ADHD, but also has pretty severe anxiety, I'm placed in a tricky situation where I'll have to figure out which one should be addressed first. And typically it's whatever is causing the most distress, like Jason was talking about, that we should be able to address first. But usually it's those kiddos that have a lot of other complexities or challenges going on that maybe have a lot of sensitivities to medicine or how they're going to react. I think we have a good amount of research and a good amount of data to support the use of stimulants in most children. in terms of like how it works, I know you asked like the science behind it, right? We know that dopamine and norepinephrine are the two neurotransmitters in the prefrontal cortex that kind of help with focus, impulsivity, decision-making, executive functioning. And stimulants tend to either stop the reuptake of those, so they increase the amount of dopamine and norepinephrine in your prefrontal cortex. And essentially it just kind of wakes up the brain, right? So they're able to sort of function like a neurotypical brain, that in a typical brain, the prefrontal cortex is the part of your brain that is involved in decision-making, executive functioning, concentration, things like that. So one of the main reasons stimulants work the best is because they directly impact that area of the brain, and they're pretty quick acting. So about the question with trial and error, I think if it's specific about ADHD, it's a quick trial and you'll see the error pretty quickly, right? Like Jason mentioned, within a day or two, the medicine is an on and off sort of mechanism of action. So when you take it in the morning, it's out of your system usually by the evening, and you can directly observe the impact of the medicine. And it doesn't create any, most of the time doesn't have any sort of long lasting errors, right? Like if you notice that your kiddo is more agitated, didn't react well, they got more anxious, they had more meltdowns, then maybe this isn't the right fit for them. So I do think that it's frustrating to have to sometimes go through the trial and error. And I talk with parents a lot of, again, you always just weigh your own concerns and worries against the benefits of the possible medicine that you're considering. And if you feel like it's worth the trial and error, then that is probably a good time to try something. But I do think it's worth conversation with the child as well, that sometimes it isn't a straightforward path and sometimes it is. And we have no way of sort of predicting which kiddo is going to do well on the first stimulant we recommend versus which one's going to need like a couple of different options.
When a child starts medication and, a parent's concerned with side effects and things, do those side effects, can you just tell us some of the common ones you see, and do they last, or do they kind of, is it like maybe the first 2 weeks or something like that, and then they subside?
Yeah, that's a good question. Typically, the most common ones that we're concerned about with stimulants is appetite suppression and sleep disturbances, right? So because it is a stimulant, sometimes those two things are probably the most like day-to-day impactful for the kiddo. If kids are coming in where they're already kind of either low weight for their age or bordering on weight, then that's something we monitor, because we know that while the stimulant is in your system, usually around lunchtime, they'll skip meals. And so again, I just work with parents to figure out how to make it work. If it's not something that's leading the kid to fall off their curve, for example, we'll just give a lot of snacks after school. We'll work with the school to be able to have snacks if the child needs, after lunch, if they get hungry. And then usually we recommend like a big breakfast and a big dinner to make up for whatever calories they may have missed during the day. But typically that's like the most common conversation I'm having with parents is around eating and making sure that the kiddo is not losing weight on the stimulant. We also recommend like weekend breaks, so that way they're not having the side effects on the weekend and they can kind of, recuperate and eat and sleep in whatever ways that they're used to. Sleep is actually interesting, because I found that kids with ADHD without medicine have a lot of sleep issues and they really struggle to have like a good routine. And so sometimes it actually helps kids. They're exhausted by the end of the day and then they sleep a little bit better. If it's leading to sleep disturbances, we just do a little bit of a deeper dive of why that is. Is the dose too high? Does it need to be adjusted? Are their parents not giving it early enough? But typically it's medicine you have to take first thing in the morning so that it doesn't interfere with sleep. I mentioned like anxiety is tricky because sometimes stimulants can make the kiddo a little bit more anxious if they're already vulnerable to anxiety. So again, if it's just ADHD, it actually gets better for a lot of kids because their anxiety is from their inability to perform the tasks or remember things, and they're feeling sort of scattered. And so when they're on the stimulant, they actually feel like everything has slowed down. They have full control over their actions, and it feels better. But a kiddo with some vulnerabilities to anxiety around other things sometimes can experience a little bit more on a stimulant, and we just monitor how that's like what's going on and how that's impacting the kid. Sometimes, you know, obviously, I think everyone has heard that stimulants can impact your heart. So depending on our history and the family history and the child's medical history, we might recommend they see a cardiologist for clearance. And it's usually just to make sure there's no structural heart defects. So most studies have shown that that's really the only sort of thing that's not even a true contraindication, but something we would have to really take seriously if there was a structural heart defect in the child himself or herself. So if there's a family history or if the child has a personal history of any structural cardiac issues, then we usually get cardiologists on board and work with them to figure out, you know, what kind of medical approach we should take to treat the ADHD. But even then, most of my conversations with cardiologists is, again, because we know these medications can be so impactful for ADHD, they really work with us to figure out a solution to help the kiddo, you know, treat some of the problems that they may be having.
With exception of the heart issue, is there, it sounded like before you mentioned the heart piece, the other side effects seem to be ones that would subside with stopping the medication. So is there any lasting effects of trying, like trialing the medication?
What do you think, Jason? I don't think so.
Not that I know of. No. So the side effects, there's different types of medications in psychiatry. Some you have to take every day and it kind of builds up a cumulative thing, but stimulants are more like taking an Advil for a headache, like it kicks in and then it wears off. So if it caused side effects, you would see it. And by taking it, you're not committing yourself to anything. So you can stop stimulants kind of whenever you want. You don't become like dependent on them or anything like that. So you could take it for 6 months every day and then go off of it. So you're not committing yourself. One perspective that I think is helpful is that if it's going to cause a problem, it's probably going to be like one really bad day. But if it works and it works 80% of the time, you could be giving your child like decades of benefit, you know? So I wouldn't be like, I mean, obviously we have to take it seriously that it could happen, that you could have some anxiety or even agitation and stuff like that. But I would say it's probably 5% of the time that happens. Like the vast majority of the time, people are happy and they say it like it was transformational. And if it's bad, it's like a bad day. But, you know, I would say it's a different calculation. If you know there's going to be a side effect and you're like, ooh, is it worth it? That's very different than if you don't know. And we would expect that it wouldn't happen. Then you definitely, if you're going to start a medicine, you have to be open to the possibility of something not perfect happening, honestly. But I would just think about the potential benefit versus that. That's how I think about it.
Do you see with the side effects to like appetite suppression after a child's on it, even if they're taking breaks on the weekend or different things, does the body kind of respond, and are they able to better manage that, or does it improve, or is that just a side effect that you kind of adapt around with big breakfast, big dinner?
I think it really depends on the kids, because some kids I'll ask them like, are you eating lunch? And they're like, yeah, like because they're so used to their routine and they're not actually trained to listen to their internal cues. You know, they know it's lunchtime, so they eat the lunch. And then other kids are already picky eaters or have a hard time eating, and then it tends to just make things a little bit worse. But because there is like a curve of how the medicine works in your system, we can actually pretty directly kind of pinpoint at what point the child would get hungry, depending on what time they're taking the medicine and when we're noticing certain behaviors pop up again. But I'll usually advise parents and teachers to like work around those times to give food and snacks and things. But yeah, typically we manage around it. It's typically not a huge issue unless it was already an issue before they started the medicine. And as kids get older, they also learn like, all right, I need a granola bar with me at all times, or I need snacks with me because I know I'm going to get hungry at like 3 p.m. So they get older. And I mean, as I have adults that sort of deal with it too, but obviously as adults, we have a lot more ability to control when we can eat and what we can eat. And maybe we have less, challenges around food. So I think it just depends on the person and the child, but the most important thing is just monitoring and making sure that we're checking their weight and we're checking their growth and all of those things. But typically the benefits usually at that point are so evident that parents most of the time are willing to work around some of those small challenges around eating.
Okay. Well, we're getting close to the end time and I want to respect everyone's lunchtime. Is there any other, I want to give a call out for any other questions anybody would like to ask? Oh, we have one. Do you provide counseling services? I'm looking for a therapist or counselor who can work with my 11-year-old to explain to her that it's okay to have ADHD and she can use her ADHD superpowers to her advantage and advocate for herself. My kid is in denial mode and has meltdown when I try to explain the reason why she struggles.
So we do provide psychotherapy for people who are looking for that. And we have the ability to do integrated treatment, which is, medication together with therapy if both are indicated and desired. So we could definitely do that if you're interested. We also work really closely with a lot of therapists in the community. And so, if someone comes in for an evaluation and we could talk about the kind of therapy we do, but if it's not a good fit, we can also refer out to the community. So we definitely do that. But yeah, well, you mentioned this idea of kind of like the underlying, how she's feeling about herself. You said, I think, what did it say? There was like a meltdown, right? When you
Yeah.
So that's a good example, when we're talking about like, when does it kind of cross a line like this, that would be an indication to me that it's affecting her in a pretty significant way that it's like hard to even talk about, So our approach, if we did an evaluation, would be to figure out what the diagnosis is. Sometimes there could be other diagnoses as well. But like from the moment I start talking to the parents, I'm already thinking the entire time, how am I going to position all of this at the end? Do you know what I mean? And with children, we're not sitting down with kids and like immediately getting into the symptoms, let's say, or like talking about it in any serious way. It's all about bonding with them initially, talking about what they're interested in. And then we can kind of explain it in ways that I think are much more palatable to kids. Do you know what I mean? Because you could be a brilliant psychiatrist, pick the perfect medication, and the person doesn't take it, and then you did nothing, So a huge part of it is that rapport, building that rapport and finding ways to kind of connect with children, which is hard, but that's what we do.
I think there's like with what you just said is so important for us to understand as adults. We're making decisions for another human that has their own opinions and thoughts about, and own struggles that we may not see, even if we're their teacher and watching them in the classroom or parent and helping them with homework. We don't have a camera or a translator attached to their brain to know exactly what their experience of working through some of these challenges are. And I think oftentimes working in the schools, I was the first one to give a just an educational diagnosis, but still a diagnosis to parents, or parents were bringing me diagnoses from their medical doctors, and we were incorporating that into a school plan. And I was the one that ended up spending a lot of time talking about that. And I was more accessible sometimes, just with the structure of school and the meetings and the frequency that we had them. So I think one of the things, like going back to that 5-year-old, if that 5-year-old who thought he was bad and now realizes I wasn't bad, my brain just needs XYZ so that it works well. And when my brain gets what it needs, just like if I get a good night's sleep, I can pay attention tomorrow and I'm not crying. Or if I take this medication, it gives my brain the food that it needs or the chemical that it needs, or however we explain that to them. And then I can pay attention and I can follow directions and I can remember the directions from the time the teacher tells me to the time I go back to my desk to actually do it. And I find sometimes when a child understands their diagnosis, and realizes it's not their choice or it's not something that they did, that it has a name and it's this and it's just something I have, and there's these superpowers that it just because my brain isn't great for a classroom without taking my medication, my brain can do some really neat things that other people might not be able to do as well as I can, and looking at those superpowers. So I think there's sometimes, depending, obviously, it sounds like this child's not ready to accept that yet, but there's a way to have the conversation, hopefully, to help her get there. But sometimes kids find it, once you start having those conversations and you break down through some of that resistance, They really do almost have a sense of relief. I know I'll just share when I shared my daughter's diagnosis with her, and hers is dyslexia. I remember I pulled, I had found some books that showed other people with dyslexia who have done really amazing things in our world. And I will say a lot of those people also have ADHD, because dyslexia and ADHD are very comorbid. Um, and when I started showing her that and showing some of the strengths that come along with it, and at this time she was really into Legos, and I was like, like, you know how you love to build Legos? And at the time, it was during the pandemic, we had the whole like spare bedroom filled with a Lego city. And I said, you know, the whole city you have upstairs, do you know that like so many, and I had the percentage then when I said it, but so many architects are also dyslexic, and they have this great strength in building things and creating things. And you just saw her relax, like, school's hard, reading's hard, but oh, I'm not alone. These other people, these famous people I've read about in books, did the same thing and they were fine. They did great things. So I think there's ways to approach these conversations. And sometimes we just have to have the hard conversation, plant the seeds, and come back and revisit. But I think you're absolutely right. Like, that's kind of your job. And I think parents can lean into you on how do we figure this out? And your evaluations would get underneath of why is there so much resistance to thinking about this or accepting this.
Yeah.
So any other big questions? And we'll let everybody get back to their day and look forward to another conversation. And if you have ideas for topics for another time, I think we have commitment from the doctors to do this again, and they're willing to bring information that's needed to our parent community here. So,
I guess I would just mention before we wrap up. So if people are interested in speaking with us and seeing us for evaluations, we are accepting new patients. We usually can see people within about a week. So we can get people in pretty quickly usually, and that would be either virtual or in person. I think that if people want to reach out to us, the best way is probably to call us. Maybe I'll put the phone number in the chat, but it's our number is 201-304-7552. I'll put that in the chat.
Natalia got it. Thanks.
Natalia, did it already?
Yep, you both got it in there.
Faster than me.
Good.
And then our website is developmentalpsychiatry.com. Oh. Okay, I don't have to do anything.
They're on top of it. Look at that team go.
Yeah. Yeah. So let us know. Yeah. You know, I know it's scary sometimes calling a psychiatrist, but as you can see, we take a very kind of like friendly and supportive approach. So, you know, it doesn't hurt to call and just kind of like, you know, talk to us a little bit if you're interested.
Well, and I have to vouch for that, because when we met, I met Divya first, and then we scheduled a meeting, and I really was, I mean, I was interested when Divya reached out first, because I was like, oh, wow, like usually I have to go beg, you know? And then we had multiple conversations, and I just, I definitely can say that I would expect if a parent reaches out, they're going to get a very engaged and collaborative approach, and those concerns that they have will be addressed through conversation before you have to make any big decisions, and that you'll have information to share with them to do that.
For sure.
All right.
Oh.
So we're going to try to share this recording out. And if you found us through social media, or you found us through the newsletter from the Center for Developmental Psychology, we'll psychiatry, I'll get it. We'll share this out and share some final thoughts and all the contact information again. But happy to keep conversations going, and feel free to contact me and share with me if there's more information you'd like. I'm sure I can reach back out and answer questions, or invite Dr. Dean or Dr. Patel into our chats to answer those questions as well. So thank you all, and thank you, Natalia, for being